Okay, well, I thank the panel for a set of very elegant presentations, and now we'll have all of the speakers come up, and we'll just make a little panel here and allow people to ask questions. And as everyone is coming up, I would just like to say a couple of words from the presentation. Actually, I think using John's presentation as sort of the hook. I think when we think about obesity, we have to think about the complexity. And so when we think about whether or not fast food restaurants in an environment affect weight status, we have to think about all the steps that go between just having that food store in your neighborhood to actually coming to consume it. And there's also from Ted's talk, I think the feeling about weight bias and thinking that there's going to be preferences for fast food across the weight spectrum. And so there are thin people who are going to love fast food. There are people who are heavier. There's just going to be a lot of diversity in who wants to eat fast food. And then I think from Arnie's talk, hearing that there's also very different susceptibilities, and those susceptibilities can be biological, but going back to John's, they could also be socioeconomic. So whether or not someone is consuming the food in and of itself may or may not be the predisposing factor. The internal mechanisms of how that food is processed and used and desired are likely playing a very big role. And then from Simone's talk, also important to think about the person as consumer and what they're confronted with in the purchasing decisions and the messages that they see and how that shapes what they wind up consuming. So I think that summarizes a bit of what we did, and I don't know if the panelists want to weigh in or if we can open the floor, but go ahead. And are these mics on?
Can you hear me? Yeah, I think that it's on. It's just a question for you, Simon. I was very curious about if you have been able to see there was any changes in the prevalence of obesity and overweight in Mexico after you started this taxation.
Well, it has been only 2 years since the implementation, and the estimated effect is per capita is about 6 calorie reduction per day. So it's very small, but even with that, the national consumption of sugar, if you estimate it, is a lot. It's thousands of sugar tons per year reduction. So, but we will need maybe like 10 years to have an effect.
I think it's simply because if your prediction is based on that this reduction in caloric intake will not be compensated by eating something else, and that's hard to know. I probably tend to agree with you that this will be the case, but it would be nice to see that this prediction is actually also turning into a reduction in overweight.
We modeled in the predictions caloric compensation of 10%, 39%, and 100% caloric compensation, and you still have benefits because the reduction in consumption of sugar has benefits even without the direct effect through body mass index.
All right, Luis, go ahead.
Louise Bauer, University of Sydney. That was a tremendous session. Thank you very much. Maybe just a couple of questions to get things going. Simone, very, very interesting to see your data. I wonder if you have any data, or is there any possibility of looking at data on dental caries and what may change over time in Mexico? That would be a really interesting co-benefit to look at. And maybe I could ask Penny to then maybe comment, if you remember after the discussion there, if you could just reflect on transport changes and things such as active transport change. Is that different from occupation transport? And if you could reflect on those issues. Thank you.
So in China, we find occupation-related activity really to be the predominant change that we see. That's where not just the biggest changes in terms of activity level, but also the strongest associations with with weight and weight-related outcomes. So it seems like that's where the action is. For women, domestic labor does, those reductions are really quite extreme as well. But for active leisure, for active transit, it's hard because it's so infrequent, and it's hard to capture relative to the other components. So.
We are not evaluating dental health in the national surveys, but there are some groups that are trying to identify databases to do this study. I agree that this could be also a very interesting aspect to evaluate from the stall attacks.
Hi, thanks for a great session. I was really interested in John's talk, and I sort of intuitively understand the idea that if you expect or you find a temporal association, you would expect a spatial association. But then part of me is also thinking that if you observe a spatial association for a cohort born, say, in the last 5 years, that doesn't necessarily mean that there isn't been a temporal association, i.e. I would still expect that fast food restaurants to have contributed to the obesity epidemic, even if you don't observe a spatial association now. Does that make sense?
Yeah, so the way that I kind of look at it is that the contemporary part of that graph, there's still a relationship happening between densities of fast food restaurants in time. So between 2002 and 2016, there's still a relationship. So we would still expect in 2012, when all the data that I presented spatially, we would still kind of expect there to be a spatial relationship. So it's not like historically there was a temporal relationship and it's now gone. It's still actually happening at the moment. But I think the way to look at it is this, that these restaurants are all pretty much the same size. They're not enormously different. So if you have 10 times the number of restaurants in an area, all the areas have about 65,000 people in. That food's going somewhere. Somebody must be eating that food. It's not being thrown away. It's actually being consumed. And yet, there's no difference in the obesity between those populations. So that as far as I'm concerned, is the real kind of bottom line here. There are actual restaurants selling actual hamburgers, and it's having zero effect on the numbers of people that are obese.
I guess my point was, do you think your findings, your spatial findings, rule out the fact or the idea that the increase in fast food restaurants has contributed to the secular increase in obesity over the last 40 years?
No, I don't think you can extend it to that.
One question also for you, John. Did you control for the volume of sales in the restaurants, or is it just density of restaurants? Because it can be that in low income, they sell 10 times more, and it's the same number of restaurants.
We didn't, that data's not available.
Mike Lean here again. John, just a very simple thing. I think the obesity figures you were using were adult obesity?
Yes.
But perhaps in fast food restaurants, a lot of children eat the food.
Yep.
So I have a question for Simon. I think we're all waiting to know whether the change in behavior, the consumption of sugar-containing beverages, will be reflected in weight change, or whether the increased sweetness of the alternatives will stimulate the appetite for snack foods and continue the increase in weight. We need to know this information. If you want to reduce the consumption of sugary beverages or even sweetened ones, did you consider banning caffeine, which is only there because it's addictive? Caffeine is added to these drinks. In Europe, it's added because it is theoretically a flavouring, but it has no flavour in the concentration used. It's added because, and Boyd Swinburne showed some data showing that adding caffeine in a randomised controlled trial increased consumption, I think, by 10 or 15%. So if you want to reduce reduction, why not remove the caffeine? That costs nothing.
Yes, that's a very important idea, especially because Mexico is like the second consumer of Coke, so particularly caffeine beverage. But when we tried to reduce the level of caffeine of the Red Bull, there was a big important trade problem in Mexico. So I don't think the Ministry of Health wants to mess with caffeine for a while. So we will need to be working a lot on that.
Mike, I don't think that's a good idea, because there's actually quite good data to support that caffeine is producing a slight weight loss. There's very good data from the Nurses' Health Study showing that those who had an increase in caffeine intake over years had a less weight gain over years, and we actually did a randomized trial for 6 months, double-blind placebo control with caffeine, and it actually showed it produced a small significant fat loss.
Fascinating. I still think it would be an interesting idea to see what happens to consumption of sweetened beverages if you remove the caffeine. It would cost nothing.
Of course, the interaction.
You could transfer it into the water.
So I have a question for Arnie. Are you doing any interventions with baseline glucose or insulin?
Yeah, you know, first of all, when we wanted when we started to design some trials, we realized that these trials were already existed with all the measurements, but nobody have analyzed them and stratified them according to baseline glucose and insulin. So we think ethically and economically it doesn't make sense to start to do new trials when they have already been done. So now we are collaborating with the Pounds Lost and also with Christopher Gardner's trial to reanalyze them and look at fiber, etc. But of course we are planning to do new trials where we actually start and also have some more sophisticated measurements. We're also doing the microbiota where we can see that there are some very important predictors based on the microbiota. So there might be some important interactions between glucose metabolism and the microbiota. So, but I think it seems to be quite robust, our findings across different trials and different populations. The only important thing is really that there's a good adherence to the diet composition. Otherwise, you know, if people are all eating the same in different arms, it's a little tricky. So I think the most robust findings is really where we have provided all the foods free of charge for 6 months to the entire family, because there we know exactly what they're eating. But this is a tricky part of dietary interventions. But I think it also solves that you know, when you see that randomized trial with low fat versus low carb, that there's essentially no difference. But then when you reanalyze, you suddenly see huge differences depending on your pre-treatment glycemic status.
Interesting.
Planning to ask you to comment on this low carb diets on obese diabetic patients. As far as I know, no national or international guidelines recommend that amount of carbohydrates in diet. Do you think that we use, in general, more than we should use consume carbohydrates in our daily routine diets? I mean, that ratio, 35%, you mentioned. Should it be the normal range that we consume in our normal lives?
Well, I think current recommendations for carbohydrate intake makes a lot of sense for the normal glycemic part of the population, but the more you move into the diabetic and the pre-diabetic, and particularly the diabetic population, you should cut down on total carbs and put much more attention to the quality of the carbs. And for the pre-diabetics, the quality of the carbs with the fiber content seems to be extremely important. So I think our recommendations are probably very good and based for the normal weight and also the overweight with the normal glycemic population. But the more you move into this insulin resistance and type 2 diabetes, you need to simply to take into consideration that the satiety effect is not as good for them. So it's a kind of carbohydrate intolerant, and it also affects the appetite, the satiety. But I think we need much more, mechanistic studies. So also to try to really understand the mechanism. The brain part is one of them. but it could also be the uptake in muscles and liver and fat that actually send signals to the brain. There's so much we don't know yet.
I'm asking this because there is a growing interest in ketogenic diets in the overall population, and we do not have long-term data, but short-term data takes into this point, low carb.
Yeah, I think the Predimate, where we have 5 years data on ad-lib diets, clearly show that there's no weight loss except in the diabetics and also the pre-diabetics with low insulin. They start to lose weight automatically. And I think that's really, something I believed in for 30 years, that the diet composition is important for your appetite control, and you can achieve a reduction in spontaneous caloric intake by making changes. But of course I've been confused by the low fat, low carb, but suddenly we can see why there is this conflicting evidence. It's simply because it depends on who you are.
Thank you.
Okay, and I have one question for Ted. Are you going to follow your people? I'm just curious. There seems to be some positive changes in media and otherwise around weight bias. I'm just wondering, are you going to follow any of these countries to see what, how things change over time?
That is our intent. We've tracked data for a little bit more than a year in all of these countries so far, and we intend to continue tracking that data. We have also been tracking data on these attitudes in the U.S. for quite some time, and what we have seen is a significant trend away from the belief in disgusting irresponsibility as being the root cause of obesity in the U.S. We see some other trends that are encouraging, but change in these kinds of attitudes are very slow. There are a number of things that we think might fuel those trends, but we think that it's important to keep tracking on them because, as illustrated by this group here, the public and policymakers bring a lot of presumptions to the table about what's going on. And sometimes that's all we have to work on, so we have to do, real-world experiments. But sometimes those presumptions get in the way of being a little bit more bold and figuring out what's really going on. Maybe we shouldn't be sweating fast food so much. We should be sweating marketing practices that puts food at our fingertips all day long, all the time. Who knows? But we need to be more. We need to unblind ourselves from those biases.
Well, I think that's a good point, that there's a lot of presumptions, and politicians who want to do something, they're maybe relying on something that, it's quite complex, I think therefore John's work is extremely important to try to disentangle. Do we really have evidence to say that the fast food is really to blame? And it's the same with the sugar. I could say that we cannot do much harm by putting a sugar tax, so that's okay. And the same with trans fat, etc. But I think we should be careful not to really rely on quite soft science and move that into legislation, because maybe we can do harm instead of doing something good.
Well, I think that's a good place to end. I'm sure that the speakers will stick around if anybody has one-on-one questions. But thank you very much for attending.